screen is visible and we begin here. So this is the QR code. अभी तक आप लोगों ने DBA का ऐप डाउनलोड कर लिया होगा, I'm sure. Right? So the second part of the thyroid module. So last class we talked about thyroid peroxidase enzyme, and we also learned that it metabolizes or intermediate every action of hormone synthesis. So it oxidizes iodine, it helps in organification of iodine, it helps in coupling of the monoiodotyrosine and diiodotyrosine to make T3 and T4. This is again the radioiodine 131 that we studied last time. It causes a progressive destruction of the thyroid cells, that is RAI, radioiodine ablation that we do. And it is used as the initial treatment at times for the relapse or after a trial of anti-thyroid drugs. So to treat hyperthyroidism, we have either the medical management, that is the drugs we studied, or we have radioactive iodine. Now, there's a small risk of thyrotoxic crisis in the initial phase. So we treat the patient for initial 7 days and we bring the patient to a euthyroid level, and then we go for RAI. Then we stop the drugs for 7 days. Of course, we give a 7 days drug-free period, and then we go for radioiodine. So that helps in minimizing the risk of thyrotoxic crisis. So patient becomes hypothyroid in about 1 year post-treatment. So whenever there is a case of hyper, always remember as a clinician that all hyper we try to bring to hypo, because the management of hypo is easier, complications of hypo are less, and the drug management of hypo, that is only thyroxine replacement, is also without any side effects. So we always try to bring all hyper to hypo. Now we can do this by thionamides, that is anti-thyroid drugs, or we can do that by radioactive iodine, or we can also do that by surgery, that is removing the thyroid gland. So pregnancy and breastfeeding are an absolute contraindications for the radioactive iodine. But patient can safely conceive after 6 months of treatment. Radioactive iodine can be used safely in children. Of course, it is safe. I have used it in patients above 7 to 8 years also. One important point is that in case of Graves' ophthalmopathy, we avoid using radioactive iodine because that worsens ophthalmopathy. So for Graves, patients with Graves and ophthalmopathy, we treat with thionamides, that is anti-thyroid drugs. Thyroidectomy, that is surgery, is one choice, but we always have our surgeries always come with their set of complications. And the most important is damage of recurrent laryngeal nerve. So recurrent laryngeal nerve passes very close to the thyroid gland, and that is why we try not to go for surgery, especially if the gland is very enlarged. This nerve may be embedded in the gland. Then hypopara. We all know that the thyroid gland has parathyroid glands on each of its poles. So we have the superior parathyroids and the inferior parathyroids. So if you go for total thyroidectomy, the surgeons try to preserve the parathyroids. But at times they fail in doing that because if the gland is very enlarged, the parathyroids are embedded, they may not be able to actually identify the gland. But still, if they are able to identify, they try to preserve the parathyroid. Somewhere they place it in the neck muscle, sternocleidomastoid, or they may even place it in the forearm. But if the patient loses all 4 parathyroids, and the patient becomes hypopara. And the most important complication will be hypocalcemia, that is tetany. For eye problems, that is ophthalmopathy, the treatment is pulse steroid therapy. So we give 1 gram methylprednisolone every 15 days for at least 3 to 4 doses. Then radiotherapy can be tried. For skin lesions, again, steroid cream is the treatment. Indications of surgery. Surgery is only undertaken if there are compression symptoms or for some cosmetic reason, or the patient is not responding to the anti-thyroid drugs, or in case there is a retrosternal goiter and we need to remove the gland because of the compression symptoms. So the toxic adenoma, again, we studied last time. It is a solitary nodule, solitary hot nodule producing the hormones T3 and T4, and it will be visible on the radioactive iodine, that is 99 technetium per technetate scan, 99 technetium uptake scan. It will be visible as a hot nodule, and the remaining gland is suppressed. Treatment here is only radioactive iodine. This hot nodule or the toxic nodules, they do not respond to thionamides. Similarly, surgery can of course be done. Similarly, MNG, that is Plummer's disease, we studied Plummer's disease, that also responds only to radioactive iodine. So toxic MNG, that is Plummer's, multiple hot nodules. The idea is to control the thyrotoxicosis first with the medications and then ablate it with radioactive iodine. Surgery is indicated in case there are compressive features. Now, hyper during pregnancy. Now, this is a very interesting concept if you want to understand. So what happens during pregnancy? During pregnancy, the hormone HCG, that is human chorionic gonadotropin, this has a structural similarity with TSH. As a result, this is rising. So as a result, the TSH goes low. Because of the structural similarity, it will help you in, it will cause the TSH suppression because the pituitary will have a signaling that there is enough TSH in the system. So TSH will go low. Now, with a low TSH, sometimes most of the gynecologists feel that that is a case of hyperthyroidism and they refer the patient to you. And also we studied during pregnancy that TBG is high. So because of high TBG, the total T4 is also high. So clinically, the biochemical picture of the lab report actually matches a high T4 in the presence of low TSH. So hyperthyroidism. But in pregnancy, we don't trust T4. We go for FT4 and the FT4 is normal. Again, in pregnancy, we don't trust TSH because we know it is raised HCG, which is causing a false depression of the TSH. But in a true case of pregnancy and hyperthyroidism, the drug of choice is propyl thiouracil because it will not cross the placenta and also it will inhibit the peripheral conversion of T4 to T3. Then carbimazole, it crosses the placenta, so it is not recommended, but the latest recommendations are in the first trimester, go for propyl thiouracil. In the second and third trimester, you go for carbimazole. What happens in the thyrotoxic storm? So during a thyrotoxic crisis or a storm, it is an emergency. It's a medical emergency, endocrine emergency. It will present with a very toxic picture. The patient may present with cardiac failure, palpitation, tachycardia, very high pulse rate, and high cardiac output state. So patient may present with CHF. Conditions that precipitate a thyroid storm, it can be any stressful illness, it can be thyroid surgery even for hyperthyroid patients, or it can be at times the radioactive iodine administration also. So patient presents with features of severe hyperthyroidism. There will be diarrhea, vomiting, fever, high temperature with acute pain abdomen, fever, agitation, confusion, even coma, tachycardia, AF, and also CHF. Managing thyroid storm is very important to understand, and that question is mostly coming in your UG exam also in the final year paper or the medicine paper. Give the management plan for thyrotoxic storm. So hydration is the first step. Always hydrate the patient because the patient is having a lot of sweating, perspiration, tachycardia. So there is a lot of water loss or volume loss. So first step is hydration. Then if there is no CHF, you treat with a beta blocker to give a symptomatic control of tachycardia and to decrease the cardiac oxygen demand. Then if there is a heart failure, then we go for digoxin, which is given IV. Then of course, anti-thyroid drugs, high doses of propyl thiouracil, which is the maximum tolerated dose. Maximum tolerated dose is 200 milligrams TDS. So we are giving 200 milligrams TDS. Propyl thiouracil is available in the market only as a 50 milligram tablet. That is the only preparation which is available. So we give 4 tablets here, 4 here, and 4 here. Then you can also give Lugol's iodine. What is Lugol's iodine? Lugol's iodine is a hyper-concentrated iodine solution, because we just read, what did we read? The Wolff-Chaikoff effect. If you give a high dose of iodine for a short time, it will inhibit the hormone synthesis. So we give Lugol's iodine. We also give hydrocortisone, that is steroids, to manage the acute crisis. Now, in case the precipitating factor is some infection, so we also give some broad spectrum antibiotics. So this is, you have to learn this. Hydration, then if no CHF, beta blocker, if CHF, digoxin, antithyroid drugs, Lugol's iodine, steroids, and antibiotics. We'll quickly revise: beta blockers, antithyroid medications, carbimazole and propylthyrosol, radioiodine, and thyroidectomy. This is the treatment plan for hyperthyroidism. Toxic adenomas, only radioiodine. You can also go for surgeries. Hyperthyroid pregnancy, go for propylthiouracil. For storm, beta blockers, propylthiouracil, Lugol's iodine, steroids, and antibiotics. And before that, hydration. Now let's talk about hypothyroidism. Last class, and we are just continuing some part. But now we are talking about hypothyroidism today. So hypo, as we all read, is high TSH and low T3 and T4, right? So hypothyroid means the thyroid gland is functioning less. So thyroid gland is less functioning means less T3, T4. Less T3, T4 means pituitary getting a signal, high TSH is needed to work more. Hypothalamus is getting a signal to release more TRH. Causes of hypothyroidism, the primary hypothyroidism we are talking here now. The most common cause of primary hypothyroidism is autoimmune. That is autoimmune, Hashimoto's thyroiditis. Then it is atrophic thyroiditis. Sometimes if you're treating a hyper, we just read our target to treat hyper is to bring him or her to hypo. So iatrogenic, that is iodine 131 treatment, will lead your hyper patient to hypo. Surgery, subtotal or total thyroidectomy, will lead to hypo. Then external irradiation because of some neck malignancies, head and neck malignancies. If the patient undergoes radiotherapy, then external irradiation of the neck for the lymphomas or the cancers will also cause hypothyroidism. In the previous years, we were only discussing endemic goiters or endemic causes of hypothyroidism, that is iodine deficiency, especially in the Himalayan belt. But now, after the government's efforts of iodinization of salt, iodine deficiency is not that common cause of hypothyroidism. Okay. So the most common cause is autoimmune. Iatrogenic can be, then some drugs. This is again very interesting. Excess iodine can cause hypothyroidism. Iodine containing drugs like lithium, then antithyroid drugs, they will cause hypothyroidism. PAS, that is para-amino salicylic acid, interferon alpha, and one important drug, that is amiodarone. So amiodarone can cause hypothyroidism. Now, amiodarone-induced hypothyroidism or amiodarone-induced thyroid dysfunction is a totally different topic in itself, because it can cause hypo, it can cause hyper. And when it causes either hypo or hyper, it can be again autoimmune mediated or it can be drug mediated. So amiodarone-induced thyroid dysfunction is a totally different topic. Maybe we can take it sometime if we get time. Then infiltrative disorders like amyloidosis, sarcoidosis, hemochromatosis, any disorder which is causing over infiltration of the organ with any particular substance, like amyloid deposition in amyloidosis, then the macrophage depositions in the sarcoidosis, then iron deposition in hemochromatosis, then scleroderma when there is a lot of fibrosis is there, cystinosis or renal thyroiditis, again a feature of fibrosis. Then a congenital hypothyroidism, the children are born with hypo features. So congenital hypothyroidism, if not recognized, not treated, will cause cretinism. So cretins are born if we miss the diagnosis of congenital hypothyroidism. But if you can treat them, it's a treatable condition. So what are the causes? It can be no gland. There is absent. Absolutely no gland is present. There is thyroid gland is absent. Then it can be because the gland is placed somewhere else, not in its original place. That is ectopic thyroid. Or it can be because of dyshormonogenesis. So at any step, sodium iodine symphotor defects are there, or there are organification defects, oxidation defects, coupling defects, release defects. At any step of the hormone synthesis, there can be defects, congenital defects, leading to congenital hypothyroidism. Then it can be transient at times, like in subacute thyroiditis, in silent thyroiditis, or it can be even postpartum thyroiditis. At times, because of the withdrawal of the thyroxine treatment in the individuals with an intact thyroid gland. Then what is secondary hypo? See, in endocrinology, if it is a defect of the organ, we call it primary. If the defect is not of the organ, but some other place, but it is leading to the organ non-functioning, we call it secondary. So secondary hypothyroid means the thyroid is okay. There is no problem with the thyroid, but it is not getting the push from either the pituitary or the hypothalamus to synthesize the hormones. So secondary hypothyroid means there is low TSH, that is pituitary defect, and low T3 and low T4, but the TRF is high. Now, TRF is not something we measure. We don't have the lab facilities to measure TRF. This is more of a theory that the TRH is high or the TRF is high, but we don't measure it. So clinically, if you find low TSH, low T3, low T4, you are probably dealing with secondary hypothyroidism. Now, if it is a secondary hypothyroidism, is it the entire pituitary which is not working? So it is hypopituitarism. So hypopituitarism can be either because of tumors, or it can be again because of the pituitary surgery, or irradiation, infiltrative disorders. It can be Sheehan's, that is postpartum hemorrhage. So those of you who have missed my pituitary class, please go to the YouTube and go through it. So what is Sheehan's? Pituitary defects, trauma, genetic forms of combined pituitary hormone deficiencies. Then there can be isolated TSH deficiency or inactivity. This is very, very rare that there is isolated TSH excess defect. Then tertiary hypothyroidism. Again, now if there is something beyond pituitary, even above pituitary, that is hypothalamic defects, then it is called as tertiary hypothyroidism. Again, we don't diagnose it because we don't measure TRF. For us, it is low TRF, low TSH, low T3, low T4. It can be anything. But if it is a hypothalamic disease like tumors, trauma, infiltrative disorders, or idiopathic, we label it as tertiary hypothyroidism. So what are the normal values, normal levels? I don't know whether you need to learn them, but if you know them, it is always better. So TSH from 0.5 to 4.5. Total T4 is from 4.6 to 12 micrograms per deciliter. The unit is important. Here it is micro units per ml. Then T3, it is 80 to 180 nanograms per deciliter. So what are the clinical features now? Hypothyroidism will do what? So at the cardiovascular level, you will have bradycardia. So the pulse rate is low, less than 60. Then there will be rise of blood pressure, that is raised systolic blood pressure, as well as one of the most common causes of raised diastolic blood pressure. So it is a hypertension, both systolic as well as diastolic BP is high. Then you can also find pericarditis. Thyroid disorders affecting children. Then it is one of the most important causes of impaired growth and development. So the children fail to attain normal height. So short stature. So children will be short statured if they are hypothyroid. Menstruation, we read, if you remember in my last class, that hyper causes amenorrhea or hypomenorrhea or oligomenorrhea, whereas hypothyroidism causes menorrhagia. There will be anemia. Now, what type of anemia does hypothyroidism cause? Interestingly, it is a mixed picture, but more often it is a macrocytic anemia. At GI level, it presents with constipation. Then there will be other features like the skin features will be there. There will be dry skin, myxedematous skin. There will be hair fall. The skin will be toad-like. At the CNS levels, there will be cerebellar ataxia, the hung up reflexes. Hung up reflexes, again, pathognomonic of hypothyroidism. The delayed tendon reflexes. Then mood swings, depression, carpal tunnel syndrome, dementia. You have the attitude to forget things. Patients come and they are like, they don't remember anything. Whether दवाई ली थी या नहीं पता नहीं उन्हें. Similarly, the BMR is low. So there is cold intolerance. ठंड ज्यादा लगती है क्योंकि उनको hypothyroidism है. Then there is weight gain. Now this weight gain is not actual weight gain. It is just what mucopolysaccharide deposition in the skin. So there is edema. So the patients who come and tell you, मेरा weight इसलिए बढ़ रहा है क्योंकि मुझे thyroid है, is not actually true. Then there can be goiter. Goiter may or may not be there. Goiter is just a term that means there is a thyroid enlargement. Thyromegaly. So thyromegaly means goiter. It can be hyper, it can be hypo. Then other features, there can be galactoria. Now, can anyone tell me why will there be galactoria? क्योंकि TSH के साथ साथ प्रोलैक्टिन बढ़ेगा. क्यों बढ़ेगा TSH के साथ प्रोलैक्टिन? ये भी हमने पिट्यूटरी क्लास में पढ़ा था, क्योंकि TRH जो है वो डोपामिन को इनहिबिट करता है. Right? So important points, the myxedema. The edema here is a non-pitting edema. जो hypoproteinemic deficiency में edema होता है, वो typically pitting edema होता है. Pitting edema आप ऐसे अंगूठे से दबाएंगे and you leave it, there will be a depression will stay, the dip will remain there. So that is pitting edema and it is a feature of hypoalbuminemia. Whereas the non-pitting edema of myxedema is a feature of hypothyroidism, because here the edema is not because of water retention, it is because of subacute deposition of mucopolysaccharide. The ankle jerk is delayed. So delayed, very, very beautiful. If you elicit the ankle jerk, you will find ankle slowly coming to its position. So hung up reflex, this is because of pseudomyotonia. The muscles are relaxed. Involvement of the musculoskeletal system will cause, in hypothyroidism, will cause myopathy, which is characterized by myalgia, proximal muscle weakness, and cramps. CK is raised. So the CK means the CPK, creatinine phosphokinase. So elevation of creatinine phosphokinase, specifically the muscle, the MM variant, the muscle variant. CPK MB is raised in, CPK MB कब बढ़ता है? Cardiac attacks में, MI में, because MB is a variant of cardiac muscle, whereas MM is the variant of skeletal muscles. So there is elevation of serum creatinine phosphokinase CPK fraction, which is seen in hypothyroidism. It can even happen in asymptomatic patients. Now muscle biopsy, which is rarely done, it will show non-specific changes, including atrophy of the type 2 fibers. Now these are MCQs. These are those MCQs which will be like the final position deciding. Like एक लिमिट तक तो सभी के सही हैं जो टॉपर्स हैं, जो लास्ट के 2-3 क्वेश्चन जो केवल कुछ बच्चों के सही हैं. So this is muscle biopsy, hypothyroidism showing involvement of type 2 fibers, atrophy of the type 2 fibers, whereas hypertrophy of the type 1 fibers. There is glycogen deposition, there is focal myonecrosis and inflammatory infiltrates. Now, this is very, very typical. There is loss of 1/3 of the eyebrows, alopecia of the lateral 1/3 of the eyebrows. Now, this, my patients, they come with a pencil, the kajal pencil, and they make eyebrows and come. Now, the carpal tunnel syndrome, this is the carpal ligament. So, carpal tunnel syndrome, because of the compression of the median nerve at the wrist. So features of iodine deficiency. Now this we don't see nowadays much, but if you remember your grandparents and or your great grandparents, you must have seen them with huge goiters. So diffuse goiter was a feature of iodine deficiency, so thyroid enlargement. Why this happens? Because the gland tries to compensate by increasing the size. That probably I can compensate by increasing the size. If my size is more, I can make more hormones. So the most common presentation is known as endemic goiter, that is because of iodine deficiencies. Most of the patients are euthyroid because the gland compensates and have normal to raised TSH. Now, despite the hypo features, these patients will have increased uptake because of the hungry gland. And the treatment is simply iodine replacement. But even if you replace iodine, this goiter will not go back. There is no shrinking of the gland. There will be no further enlargement, but the shrinking of the gland is not there. So to diagnose primary hypothyroidism, you have raised TSH and low T3, T4. For secondary hypo, both everything is low. Dyslipidemia is a feature of hypothyroidism and LDL is typically raised. Then there is microcytic, macrocytic anemia or a dimorphic anemia. This is another MCQ. The type of anemia seen in hypothyroidism is a dimorphic anemia and is associated with pernicious anemia in some 12% of the cases. Other lab findings will be there will be raised enzymes, that is CPK, liver enzymes, OTPT will be raised, especially the aspartate OT or AST. LDH will be raised. There will be hyponatremia. Now, this is very, very important because sometimes you will get a patient who will be referred to you only for hyponatremia. And if it is a hyponatremia, you have to rule out hypothyroidism because in hypothyroidism, there will be euvolemic hyponatremia. So hyponatremia can be hypervolemic, that is hypervolemic volume is very high. So there is edema as well as high sodium. So hypervolemic, a lot of excess of high salt intake has been done along with a lot of water intake. So hypervolemic. Hypovolemic, that is because of dehydration, a lot of vomiting, loose motions, the body has lost water as well as sodium. So hypovolemic hyponatremia. What are the causes of euvolemic? Like volume is normal. So euvolemic hyponatremia typically seen in SIADH. What is SIADH? Syndrome of inappropriate antidiuretic hormone. Again, this we read in the pituitary class. So hyponatremia is a feature of hypothyroidism. Treatment is simple. You treat with levothyroxine. That is the only treatment. Now we have available T3 also. Liothyronine is also available in the market. 5 micrograms, 20 micrograms, 2 doses are available. We ideally treat with T4 thyroxine. We don't treat with T3. So we start the treatment with thyroxine. In children, we treat them in congenital hypos. We treat them from day 1. So along with the mother's breast milk, which is expressed, we treat the children with levothyroxine. Elderly ischemic heart disease patients, we start with low doses, slowly build up titrate to reach the targets, increase gradually in 25 micrograms every month. Quickly revising hypothyroidism. Clinical features, toad-like face, myxedema, there can be ataxias, relaxed delayed ankle jerk, carpal tunnel syndrome, alopecia, specifically the lateral 1/3 of the eyebrows. Lab findings, raised TSH with low T3, T4, primary, all low, secondary, raised CPK, raised LDH, and hyponatremia. Euvolemic hyponatremia. Treatment, thyroxine, and very slow. In elderly patients, you go very slow. Dose, you may not be asked, but if you want to remember, it is 1.6 micrograms per kg body weight. Thyroiditis. So thyroiditis, it can be acute because of bacterial infections, fungal infections, drug-induced or radiation. So acute thyroiditis, any bacteria, most commonly staph, strep, and enterobacter. Fungal like Aspergillus candida, coccidioiditis, histoplasmosis, Amiodarone can give you a mixed picture of anything. So it can cause thyroiditis, amiodarone-induced thyroiditis, AIT, then radiation thyroiditis. It can be after iodine 131 or it can be because of neck thyroiditis. Subacute thyroiditis. Now, subacute can be silent. That means the patient has no symptoms, no features. This is seen in postpartum thyroiditis. Or it can be viral or granulomatous thyroiditis. Now, viral or granulomatous thyroiditis will be painful. Then it can be mycobacterial infections, which is again very rare, but it can be there. It presents as subacute thyroiditis. And viral or granulomatous thyroiditis is a painful condition. Chronic thyroiditis, again because of autoimmune, as is seen in Hashimoto's thyroiditis or atrophic thyroiditis. Riedl's thyroiditis, another condition causing chronic thyroiditis. Then parasitic thyroiditis, that is strongyloidosis, echinococcosis, and cysticercosis. We will discuss Hashimoto's thyroiditis because that is the most common and cause of hypothyroidism. So Hashimoto's thyroiditis, it is a variant of chronic lymphocytic thyroiditis. So it is a painless condition and it is an autoimmune condition. It is an autoimmune condition, causes goitrous hypothyroidism. There can be a gland enlargement, but this will be non-tender, rubbery on palpation, and the gland moves with the tongue movement. Like if you ask the patient to show the tongue, the gland will move up. Pathology-wise, the thyroid has mononuclear infiltrations consisting of lymphocytes and the plasma cells. That is why it is called lymphocytic thyroiditis. Now, there are several well-developed germinal centers are present. The thyroid follicular epithelial cells, these follicular epithelial cells, they undergo a plastic change. And there are large oxyphilic cells with granular cytoplasm, and these are known as Hurthal cells. So Hurthal cells are seen not only in follicular adenomas, Hashimoto's, they are also seen in follicular carcinomas. So Hurthal cells are basically the follicular epithelial cells. They develop large oxyphilic cells here with granular cytoplasm. This is what you can see as the Hurthal cells. Here it is a Hurthal cell with a granular cytoplasm. Most commonly seen in women. So all autoimmune conditions will have a gender bias, and women will always be affected more than males. There will be anti-thyroglobulin antibodies, that is TGA antibodies, or there will be TPO antibodies. So there will be TPO antibodies. TPO is also known as TMA. So TMA, TGA antibodies will be present in Hashimoto's thyroiditis. It is usually not associated with ophthalmopathy, but rarely it can be associated with ophthalmopathy also, which is very, very rare. Dermopathy is never seen. Dermopathy is a typical feature of Graves' disease, that is thyroid acropathy or pretibial myxedema that we read in the last class. ANA can be present. Now, anti-nuclear factors can be present because of the autoimmune nature, and any of the antibodies can be present. It may be associated with other autoimmune conditions like SLE, Sjogren's, rheumatoid arthritis. Treatment, we just read thyroxine replacement. Thyroxine replacement 1.6 micrograms per kg per day. Because of the lymphocytic infiltration, it increases the chances of NHL, that is non-Hodgkin's lymphoma, or a B-cell lymphoma. Now, there are certain important points. What is hashitoxicosis? Also known as HTX. What is hashitoxicosis? Sometimes what happens that when the autoimmune attack happens on the gland, there is release of the stored or the preserved hormones. So these hormones are released. So the clinical picture is of toxicosis, that is thyrotoxicosis. But this thyrotoxicosis is followed by a short phase of, there is a thyrotoxicosis, then a phase of a hypothyroidism, then patient can be euthyroid for some time, and then finally the patient is hypothyroid. So this sine curve, this wave, So there can be a phase of thyrotoxicosis when the antibodies are actually present. And if you go for a scan, the scan will give you a clear picture. There is no increased uptake. So that phase is known as Hashimotoxicosis. So it's a transient hyperthyroidism which is caused by inflammation associated with Hashimoto's thyroiditis, disturbing the thyroid follicle, resulting in the release of the stored thyroid hormones. So chronic autoimmune thyroiditis, that is Hashimoto's thyroiditis, this is the most common cause of hypothyroidism in the world. Sometimes it is associated with transient hyperthyroid phase, which is called Hashimotoxicosis. It is actually thyrotoxicosis plus hyperthyroidism plus Hashimoto's a mixture. It's just a slang. It's a misnomer. It's a self-limiting phase lasting for a few weeks, maximum 4 to 6 weeks. And then it is ultimately leading to a euthyroid phase and then finally to a hypothyroid phase. So the classical features of mild to moderate hyperthyroidism may be present with a firm, painless goiter. Thyroid scintigraphy will give you a normal picture. Antibodies are often positive. Ultrasound and Doppler is a useful test. It will give you the increased vascularity of the gland. Combination of the clinical features, thyroid functions, and radiology will help you in making the correct diagnosis. Hashimoto's encephalopathy. If the condition goes untreated, like if you don't treat hypothyroidism, then ultimately the brain is affected. Okay, there is edema, there is myxedema, and myxedema affects the brain also. There is edema of the brain itself. As a result, the patient goes into confusion and finally coma. And that is defined as Hashimoto's encephalopathy. And this is a steroid responsive condition. And it is, of course, antibodies are present. There will be myoclonus. There will be slow wave EEG. It is steroid responsive condition. So let us revise this. We read in the last class. What are the conditions of thyrotoxicosis that decreased radioactive uptake? It was one most important was thyroiditis. That is thyroiditis. Of course, it is seen in thyrotoxicosis factitia, struma oberoi, or excess iodine ingestion and amiodarone therapy. So conditions of thyrotoxicosis with decreased uptake, it is a transient. If it is thyroiditis, it will be a transient phase. That is a hyperthyroid phase followed by hypo. Coming to the subacute phase, the D. Quervain's thyroiditis. Now, subacute or the granulomatous thyroiditis, when you talk of granulomatous thyroiditis, it is because of fever, it is because of viral infection, it is a painful condition. That is what we read. Granulomatous thyroiditis, D. Quervain's thyroiditis, because of viral infections, viral fever, it is a painful conditions. Features of transient thyrotoxicosis followed by hypo, followed by euthyroid, hyper, hypo, and then euthyroid. Involvement of the thyroid gland in subacute thyroiditis can be patchy. The whole of the gland may not be involved. There is initial neutrophilic infiltration, predominance followed by lymphos, histiocytes, and multinucleated giant cells. The thyroid follicles are disrupted and multinucleated giant cells surround the fragmented colloid. Thyrotoxic phase followed by a hypophase. The thyrotoxic phase is only because of this fragmented follicles. Most of the patients will eventually recover without any residual thyroid defect. Antithyroid, like the TPO antibodies, the thyroid peroxidase antibody titer is not elevated here because it is not an autoimmune condition, it's a viral condition. Most patients will respond to simple NSAIDs, simple painkillers are needed, and the most effective painkiller is indomethacin. Another MCQ, they will ask you which NSAID you will prescribe to your patient. Ideally, indomethacin. On a lab evaluation, a typical picture of inflammatory condition. So there will be raised ESR, raised TLC. Uptake is low because it's a thyroiditis. Antibodies are negative because it is a viral infective condition, not an autoimmune condition. Transiently, hormones are raised, so TSH will be suppressed. A typical term is leaking thyrotoxicosis. That is a very, very important term, leaking thyrotoxicosis. And on it is becoming hypothyroid. So the T3, T4 is low and TSH starts rising. And finally, everything becomes normal. Treatment is simple painkillers, NSAIDs, no opioids, no steroid analgesics, no steroids. Only symptoms, and that too most effective is endometriosis. Regresses spontaneously in 4 to 6 weeks time or maximum 8 weeks time. Now, Riedel's thyroiditis. Now, Riedel's thyroiditis is a fibrotic condition. So there is entire thyroid gland is replaced by fibrosis. There is very hard, firm, stone-like on palpation. The gland becomes very hard, stone because of fibrosis. So it's an insidious condition. Gland is enlarged more than in women. It is because of IgG4, again another IgG4 antibodies, cytokines, T cells, and they all stimulate fibroblasts, which replace the normal thyroid tissue. So the normal thyroid tissue is replaced by fibroblasts. There is a lot of fibrosis, and that is why the gland is stony hard. बिल्कुल stone जैसा था, firm feel आएगा आपको. There is dense fibrosis that disrupts the normal gland architecture. It can extend out the capsule, and still that function may not be evident. Like the gland may still be functioning normally. Still, the gland is no pain. It is asymmetric and they're fixed gland. Fixed glands means you ask the patient to take a water sip, they take a sip of water and the gland does not move. You ask the patient to protrude the tongue and the gland does not move. So you will think that there is fixed gland, that means there is a malignancy. But on biopsy or FNAC, you will just get fibrosis. Local symptoms due to compression of the esophagus, trachea, neck veins, or recurrent laryngeal nerve. Diagnosis requires open biopsy. FNAC is usually inadequate. Treatment is surgical to release the esophagus, because just behind the esophagus, just behind the trachea, there is trachea and there is esophagus here. So there is compression because of thyroid gland enlargement, causing difficulty in breathing and difficulty in deglutition. Tamoxifen may be useful. So the treatment for Riedel's thyroiditis, another MCQ, is tamoxifen. So this is a typical cut section of the Riedel's thyroiditis. You can see this is a normal follicle here. And here, eventually, the gland is getting filled with all fibrosis. All fibroblasts are there. There's only fibrotic tissue. So what are the other fibrosing conditions in the body? Let's see. Multifocal fibrosing syndromes. There's fibrosis all over the body. Now, these are all MCQ questions. You can take a note of this. So if the fibrosis affects the palms, what you get? Dupuytren's contracture. Then there is Perry's disease. If the fibrosis of the your mucous membranes. Then there is retroperitoneal, that is Ormond's disease. Mediastinal fibrosis and Riedel's fibrosis, that is we just read the Riedel's thyroiditis. So how do you differentiate the various thyroiditis? Hashimoto's is autoimmune, subacute conditions will be viral, Riedel's will be fibrotic. Here the gland will be rubbery, autoantibodies will be present here, no antibodies, no antibodies. All other autoimmune conditions can be present with thyroiditis, like Addison's, type 1, vitiligo, pernicious anemia, whereas subacute thyroiditis will be painful with fever and raised ESR and raised counts, TLC will be high. Riedel's thyroiditis, no antibodies, no pain, no fever, there will be compressive features and the gland will be stony hard. So in Hashimoto's, the gland is rubber-like, it is mobile, it moves on the tongue with tongue and with deglutition. In subacute, it is tender, it is painful. You touch the gland and the patient will scream. It is stony hard here. You can feel the gland, it is just like a stone. In Hashimoto's thyroiditis, patient will be hypothyroid, but there can be a preceding phase of hyperthyroidism. In viral thyroiditis or subacute thyroiditis, there will be a phase of thyrotoxicosis followed by hypothyroidism followed by euthyroid state. In renal thyroiditis, patient is initially euthyroid, but eventually the patient may become hypothyroidism. Treatment is thyroxine replacement, only NSAIDs, and it is tamoxifen. Coming to the lymphocytic thyroiditis or another variant of silent, painless, postpartum thyroiditis. Now this is transient again. There can be transient thyrotoxicosis to begin with because the stored hormones are released, affecting females more. Symmetric non-tender goiter. Thyroid functions will initially be raised T3, T4 with low TSH because of the thyrotoxic picture. Eventually it becomes hypothyroid because of the depletion of the stored hormones. जितने थे वो सब उसने निकाल दिए बाहर, अब वो खाली हो गया तो वो हाइपो हो गया. Radioiodine uptake will be decreased. ESR will be normal. It will last for few months. It may recur with the next pregnancies also. Treatment is you just treat the toxic phase, that is with beta blockers. So dyshormonogenesis or what is Pendred syndrome? Another MCQ, what is Pendred syndrome? Dyshormonogenetic goiter along with sensory neural deafness is known as Pendred syndrome. So what happens during pregnancy? If a patient is hypothyroid during pregnancy, you will have a woman with hypothyroidism, you will have to increase the dose by, we increase the dose by 25%. Like if the patient is on 50, you give another say some 12% or some 12.5, that is you make it 62.5. If the patient is on 100, make it 125. And that is because, no, this is some error here and there has been some error. Why this happened? This is because of the increased fetal demand. So the fetal axis of a hypothalamic, pituitary and thyroid axis. So the fetal axis develops after 20th week of gestation. So in the initial phases of its development, the fetus is dependent on the mother for its thyroxine supply. And we know that the brain development is happening only in the first trimester. So in the initial 3 months, of 12 weeks, the brain development is maximal. And the thyroxine is responsible for the brain development. And this thyroxine is coming from the mother. In cases of coronary artery disease, if the patient is hypothyroid, say somewhere around whatever, say 20, even up to 20 or even up to 30 TSH, we will say do not treat the patient before surgery. Let the patient undergo a bypass and then treat. Because if you suddenly increase the metabolic rate by giving thyroxine, you may precipitate cardiac failures. So in elderly patients, especially known with CAD, start with the low doses of thyroxine, lowest possible dose. You don't follow the formula of 1.6 micrograms per kg. So in elderly gentleman is 80 years and he has a CAD and his weight is say 100 kgs. You don't start with 1.6 micrograms. So chalo abhi seedhe 160 se start karte hain. No, you don't do that. You start with a small dose and slowly build up. In hypothyroidism, the metabolic rate is actually low and the myocardial oxygen demand is also low. Now, if you suddenly treat, you will increase the myocardial oxygen demand, which the coronary arteries will not be able to meet. So you will precipitate coronary ischemia, MI, or even cardiac failure. So what is myxedema? Coma. Again, this we just read, depressed level of consciousness. So because of the prolonged hypothyroidism, if the patient fails to see a doctor and the hypothyroid condition lasts for a longer time, TSH keeps on rising. And if it is more than 500 at times or maybe 600 TSH, there will be cerebral edema. So that will cause loss of consciousness. The body temperature will be dropped. It can be even less than 25 degrees centigrade. Patient may develop convulsions and the CSF pressure and the protein contents are raised. Again, another MCQ. Myxedema coma is associated with raised CSF proteins and raised CSF pressure. What are the factors contributing to the altered consciousness level here? It can be because of cardiac failure, it can be because of infections, it can be because of dilutional hyponatremia, that is again SIADH, that is euvolemic hyponatremia. There will be hypoxemia, there will be hypercapnia because of hypoventilation. The patient is not taking the breathing is altered and there is decreased breathing. So the patient is not breathing. So there is increased CO2. CO2 retention is there. So hypercapnia. Then there can be hypoglycemia, again because of the decreased intake, and other hormones are also decreased, like there is depression of the other counter-regulatory hormones. Treatment, it is a medical emergency. Another medical emergency, endocrine emergency. We just read one, that is thyrotoxic storm, toxic storm. Another is myxedema. Now with the latest medical facilities, these diseases we see very, very less. We hardly see a toxic crisis or a myxedema crisis. Treatment is you treat with IV hydrocortisone. Initially, first thing you give is IV hydrocortisone. Then, of course, you give T3. Now you have T3 available. Initially, T3 was not available, but now you have T3. But the parenteral T3 is still not available with us. So we give oral T3, that is through our Ryle's tube. Then we also give thyroxine. The only child, why we are preferring T3 here? Because T4 has a T half of, what is the T half of T4? Pharma में second year में पढ़ा है ना आप सबने? Thyroxine का T half कितना है? 7 days. That is why whenever you treat a patient for hypothyroidism, you follow up after 4 to 6 weeks, because it will take at least 4 T half to stabilize the dose. So if in a case of myxedema coma, if you give thyroxine, it will take a lot of time. That is why we prefer giving T3. T3 का T half कितना है? 3 to 4 hours. That is why T3 is preferred, and T3 is given twice a day. It is given in a BD dosing. Then you go for slow rewarming of the patient, give broad spectrum antibiotics, also give high flow oxygen. Now, what are the drug-induced hypothyroidism? Lithium is one. Lithium is used by the psychiatrists. Then interferon alpha can cause hypothyroidism. Interleukin 2 can cause hypothyroidism. Now, amiodarone-induced thyroid dysfunctioning is a totally different topic, as I told you. Just to give you the gist of it, the amiodarone has high iodine content. It has got around 37% iodine. And that is why whenever a patient started on amiodarone is prescribed by cardiologist for what? Anti-arrhythmia, for arrhythmias. So it is an anti-arrhythmic. So if you give amiodarone, because of the high iodine content, the thyroid dysfunction is bound to happen. So it can also cause, amiodarone is also structurally similar to thyroxine. So it also contributes to the effects of amiodarone on thyroid function. So it can cause hypo as well as hyper. And it can also cause autoimmune induced, or it can cause disease induced. So it is type 1 and type 2. Now, each tablet of amiodarone, that is 200 grams, will contain 75 milligrams of iodine. What is the recommended dose of iodine? 150 micrograms. And here we are giving 75 milligram iodine. And amiodarone is given how? TDS. So what are you doing? You are giving 75 milligram TDS. Then amiodarone is lipophilic. So it is also stored in the adipose tissue. So this iodine is slowly released. And that is why it inhibits the hormone synthesis by the Wolff-Chaikoff effect. Now the thyroid function, it should be checked every 6 months. Hyperthyroidism because of Jod-Basedow effect can also occur because of the slow release from the system. Now amiodarone-induced thyroid dysfunction is classified as type 1 or type 2. Type 1 is autoimmune. It occurs in patients with underlying thyroid pathology. Like there's already an autoimmune condition, maybe Graves, maybe Hashimoto's, so they will be more affected. So do you treat with the antithyroid drugs? If it is type 2, it is resulting from amiodarone causing subacute thyroiditis with the release of the preformed thyroid hormones. So you only treat with the steroids. Quickly revise the LMRPs for the thyroiditis. It is acute, bacterial fungal amiodarone radiations, subacute, silent viral mycobacterial, chronic, it is autoimmune, Riedl's or parasitic. Hashimoto's, most common cause of hypothyroidism, most common autoimmune condition, non-tender rubbery gland, Hurthal cells, anti-TGA and anti-TMA. Hashitoxicosis, transient phase, initial phase, thyroiditis. Hashimoto's NCAF, again, steroid responsive NCAF. Subacute, that is granulomatous thyroiditis, dequervains, or a viral thyroiditis, which is a painful condition, painful enlarged with fever and increased TLC. Transient thyrotoxicosis followed by hypo, followed by euthyroidism. Raised ESR, decreased uptake of the radioiodine. It will regress spontaneously. Riedl's thyroiditis, stony thyroiditis. Painless, goiter, hard, non-tender, asymmetric, suspicious of malignancy. Treatment is tamoxifen. Lymphocytic, postpartum, transient again, decreased uptake, normal ESR, improves in few months. Recur every pregnancy, it might recur. Treatment is beta blockers. Drug-induced, lithium, interferon alpha, interleukin-2, amiodarone. Dyshormonogenesis with sensory neural deafness, Pendred syndrome. Hypo in pregnancy because of increased demand, increased fetal demand. Hypo in CAD, start with a slow dose, lowest possible dose. Myxedema coma, treat with IV hydrocort plus T3 and T4. So that is about thyroiditis and hypothyroidism. We are not beginning with tumors because it will take another 1 hour. So let's revise. Let's give a quick, what do you call? One round of applause for Dr. Pratham Vyas. So Pratham, very, very congratulations, beta. आपने सारे सवाल सही बताए. He has answered all the questions correctly. So for today, देखते हैं अगली बार किसको हमें ताली बजानी. We'll clap for whom next time. Let's revise quickly. So what is the most common autoimmune cause of goitrous hypothyroidism? What cells are characteristic of Hashimoto's thyroiditis? Which antibodies are present in Hashimoto's thyroiditis? What is hashitoxicosis? And what is a key risk associated with Hashimoto's thyroiditis? Simple. सारे आते हैं आपको, मुझे पता है आपको सब आते हैं. So quickly, sir, जल्दी से सारे आंसर्स भेज दीजिए. Send me all the answers on 8851659360. If you want this class quick recall questions PDF, or you want this anything from your from this class, from this lecture, please let us know. Thyroid की tumors आप अपने आप कर लेना. You can subscribe to DBA. You can attend to the lecture on YouTube again, revise it again. Next week हम adrenals पढ़ने वाले हैं. Next week, Tuesday, adrenal part 1. Thursday, adrenals part 2. Same time, 8 to 9. For the quick revision, you can read Mini Harrison's Medicine Simplified by Dr. Bhatia. So these Zoom classes will continue. जब तक आप पढ़ना चाहोगे, तब तक I will teach you. So next class on Tuesday, 25th November on adrenal glands part 1. This is the timetable. Once again, revising the endocrine's timetable for this month. We have done with pituitary, completed thyroid. Next week, we will complete adrenals. Once again, the QR code, you can download it, your apps. For any query, you can always write to us, drop a mail, student support at the rate of Bhatia.com, at drbhatiaacademy.com. Thank you, bachcho. Thank you very much.